trying times that you have kept so many of our colleagues busy.
Thanks.
And I think interaction with each other is the key, and I think most of us who are on this chat and all the physicians who will join in are so much used to meeting for sure so many times a year, and now there's nothing, so we cannot bounce our ideas. So I think this is fantastic. I think this is a very, very good idea, Satya and Usri, of course.
Right. I think the whole credit goes to this the advisors like Dr. Nageswar Rao, Dr. Bharat Dalvi sir, Dr. Shivkumar, who gave this idea, like, and then we started on that. Last time, like last week when we did, like we had close to 400 participants. Like, it was huge actually. Right? Right now we have got around like 120 now. Right. So that's good. Right.
So
tell me, are you guys doing any scheduled elective cases? Can you? Okay. Shall we start?
So Bharat sir?
Yeah.
Doctor.
It's 4:30.
Yeah.
Okay. I'm also having my morning coffee, by the way.
Yeah.
That's the best way to present. So Usri initially and Satya later on contacted me to see, if I will be able to join in. And coincidentally, a week before that, a couple of weeks ago, I was talking with Bharat, and he stated that he was trying to do a lot of things with web and staying in touch. And also the best part of that was that the junior faculty was significantly involved with this. And then when Usri contacted me and said if I wanted to do that, I said that'll be good to see good friends, at least face to face, may it be through Zoom or computer. So they asked me a topic, and I said, so that I don't have to really work hard, I said, let's talk about what are the best practices in embolized devices, retrieval process. So we were starting with this. So first thing is, no matter what type of device you're using, may it be Lifetech device, may it be Occlutech device, may it be Embolized device or any other device, you have to know the characteristic of the device. I think it's so crucial about this. I think most of us are experienced and know about it, but for the junior faculty, you have to know where the female screw is. So for example, in a PDA device, the female screw is actually dipped inside the wire mesh, so it's not easier to grab. Similarly, in the muscular VSD device or implants, it's slightly deeper than it would be for an atrial septal defect occluder device. So that's why AST device, which probably is the commonest device that we retrieve, it's easier to retrieve, and it's difficult to get muscular VSD device, grab it. I'm not saying it's difficult to retrieve, but to grabbing it is not that easy. Similarly, PDA device, sometimes people have a very hard time, especially when they are in the pulmonary arteries and you're trying to grab the female screw. So knowing the characteristic of the device, paying attention to it for a couple of minutes, looking at it, could save you a few moments of grief if that were ever to occur. So I'm sure this was the most embolization, was the most feared complication when we started doing atrial septal defect closures and patent foramen closures. So I think there are several features, and I am a big fan of anatomy, as you know that. There are several anatomical features of the atrial septum. I think that may make it prone or higher increase in the risk of embolization of devices. And there are definitely types of defect that will increase the risk of device embolization. And we'll try to figure some of these things out. And I will be very happy to know, because I know there's very, very good people who have joined in this meeting to get some of their ideas as well. So anatomical features and types of defect may increase the risk of device embolization. And then after the device has embolized for A, B, C, D reason, when it is feasible. For me, it is very important to know when we should drop the ball and say we should not attempt to do this and may just open the chest and take this device out. What to use, and when absolutely make sure that we have to involve our other colleagues with this. So the incidence, very quickly going through it, in the atrial septal occluder trial, the original trials conducted more than 20 years ago, was 1.1%. Overall reported incident in the literature over from 2000 through 2008 or 9 cumulatively was about 0.9%. And acute embolization was luckily the most common. So people knew it before the patient actually left the lab or went home the next morning. Late embolization, which is difficult to define, how do you define late? So I always consider late embolization if the patient has left the hospital and you see the patient a week or month later and the device is embolized, then you have to worry. You don't know exactly when this happened. So I think that will be late embolization, and that's luckily very, very rare. Now, there are definitely several published series, not series, but case reports of it. And I have quoted two of them. One was in the CCI in 2005, one was in the JTCVS in 2006. And these were the only two reports up to 2014 or so, where they actually, in one of them, they documented follow-up, like even 6 months later, and then found the device embolized beyond 6 months later. So that was absolutely an enigma. And there was one case from Australia that was sent to me directly, and that case, they found the device embolized in the right PA almost 18 months later. But again, they had absolutely no follow-up on that patient for almost 18 months. So I would not be able to document that if that occurred acutely or that occurred in the next morning, if you will. And then the CCI paper, there was absolutely no documented follow-up. I'm very much aware of that case. Was done in Atlanta. And I know that discharged the patient the same evening. Okay, so I think it's a very good idea to maybe a chest X-ray in a complicated. Now we know it in a complicated anatomical case. It's never a bad idea to do a chest X-ray about a week later, so you at least know that if embolization has occurred. I have not, personally speaking, in our own experience of more than 2,000 cases, no late embolization. Absolutely, we have had acute embolizations, don't get me wrong, but luckily no late embolization has occurred. So what are the complex defect? How would you define a complex defect? This is my definition. Feel free to sugarcoat it or salt coat it or once I finish my talk. So one is if it's unusually oval defect. To me, that's a complicated case, especially if it's not evaluated well. So one side of the device, one aspect of the device will be undersized in this case. For me, a patient with IVC rim absence is a very high risk case for device embolization. You can do it, but do we have to? But for me, a patient who has a very thin and flailing atrial septum, which is hypermobile as well, is very difficult because the device tends to move back and forth to and fro in so many ways that I think it does increase the risk. For me, at ASTs, I have seen a bunch of them where the device AST is dynamic in nature. Means during atrial systole, it could be 8 or 12 millimeter diameter, and then atrial diastole is like 20, 24. And those are the defects. It's very difficult to figure out. Of course, you're going to balloon size or whatever, figure out, and I think people can make some mental mistake in that. And then for me, another one will be if the patient has multiple defect with minimal tissue separation. And with that, I mean is a lot of time you put the device in, what happens is over time, the waist of the device can actually tear the, tear the septum that separates the two devices, and it becomes one defect. And if that defect is bigger than the device that you put in, the cumulative defect, of course, there will be device embolization. This is a elastomeric model of a true human heart that we did. And you see this patient has absolutely no IVC rim present. And this patient had device embolization and John Carroll was kind enough to give this to me after they did to find out what happened in this particular patient. So let's quickly go through this example. This is intracardiac echo in a very simple patient. You can see this is the home view on the left side, tricuspid valve, RV, RVOT, aorta here, if you can see my cursor. And one of the important things you can see, you can immediately recognize that the septum is really, really thin and mobile in this case. This is what you call the septal view or the atrial view here. Atrially, this is the coronary sinus, atrial septum, absolutely more than two defects, if not more than two, at least two defects. Superior vena cava will be in this location. So this patient underwent balloon sizing of the defect. You can see that balloon has gone through this defect. Shunt is seen despite more than adequate waist CC on both sides. And then the physician who did this case inflated the balloon further, minimal shunt. Here is the waist. Okay, and this he did the balloon sizes per recommendations. Okay, and then a device was placed in this particular patient. Right there, you can see that the edge of the disc is already protruding into the right atrium here. Okay, and that's to me a no-no sign. And here, after device was released, looks fine. But again, here's your aortic rim. Here's your aortic rim. Device is already towards the right atrial side. Okay, and guess what? Guess what? Yeah, and later on, and this is again the septal view. Very nice device position. No bulking. No change in the device. But the device embolized in this patient and was retrieved by the physician. Now, in this particular case, the device embolized because when I received the notification from this physician with the data, I'm sure you guys know that I reviewed every case that used to go to AG and St. Jude Medical and an earlier Abbott Medical. Every complication that occurred, it used to come to me. So I have like 1,000 probably cases of every potential complication. So it came to me and I looked at it, and then my judgmental inference to this was that it was the inability of the operator to recognize multiple defects. And actually they did not mention it once in the report. And they went through the smaller defect, as you could see, because you had adequate waist on both sides. And when they inflated it, they literally stretched that defect to bigger thing. But actually, there were so many multiple defects that overnight, when the septum gave in, the device was too small for the two defects, and the device embolized. Okay, so here's another case. ASD. This is under TEE guidance. This is a smaller child. You can see significant right atrial, right ventricular enlargement in this patient, atrial septal defect. No need to go through that. This is a definitely four-chamber view, as you can see. Come on. This is the bicable view. I mean, right now, I mean, immediately in this picture, you can see this very good superior vena cava vein rim, but you can see it's kind of almost disappears. IVC rim tends to disappear. It's definitely, I'm not saying it's not there. Please don't get me wrong, but it almost tends to disappear. Here is, you can see a glimpse of IVC rim, good SVC rim in this patient, large right atrium. This is balloon sizing being performed by the physician who did this case. Aortic rim looks fine here for our definition. Not for IFU maybe, but for our definition, you know, we don't care about aortic rim. Even 1 or 2 millimeter for us is adequate as of, you know. So they put this device in, and right now, you know, this is a poor device positioning without any question. If you look at this carefully, this is literally poor device. Almost this looks like a device is undersized in this particular patient. And sorry, some hitch about, okay. So, and then they changed the device, put a slightly bigger device. It tends to straddle the aortic rim very well. You can see it's very thin over there, but it's almost always very difficult sometimes to look at the IVC rim if it is literally being captured or sandwiched or not. And they thought the device looked okay. They did wiggling. Bicable view looked okay in this picture, but device embolized, as you can see, went to the right atrium and then went to the right ventricle in this patient. It was absolutely retrieved percutaneously, if I remember correctly. Okay, In this, I think there were multiple factors. Initially, they undersized the device, but they took care of that. Could it be still undersized? I'm not sure. I would be happy to take your view from it later on. I think it was definitely inadequate IV syringe. It wasn't absent, but it was very thin, perhaps a little bit smaller than the kind of rim that I would like, to be honest with you. Not that I would not have done this case or not attempted this case. So the take-home messages from this will be that IV serum usually is the most flail rim, and hence its adequacy is important to ensure that the device will remain stable. The device will always embolize to the right side. This is a fact which is very as weird as it sounds. Almost always the device embolizes 4 to 6 hours later or at night, and then they call you, the patient has arrhythmia. Okay, and it almost always embolizes to the right side because the device over time gives in, slides over the IVC septum, and then gives in. Quickly giving you the example. See this, I hope you can see this. This is a patient who has, you can call it ASV, you can call it PFO, it's somewhere in the middle. Right now here you can see this is the short axis view. This is the sort of bicable view here, and this is the limbus. IV. This is the septum primum, coronary sinus, right atrium, left atrium, intracardiac echo being done. You can see good shunt here. It's a slant shunt, so you can call it PFO if you will. You know what I'm saying? The operator did the balloon sizing here. You can see the measurements, and based upon those measurements, they decided in this particular case to put an atrial septal defect device. And you can see the device is placed in this picture. Remember, these pictures were sent to me, so I cannot manipulate these. I could just copy them and then put them in the thing. So you can see a couple of things, and those who are experienced already have figured out what will go wrong in this particular case. Okay. And this is still the device. I believe the device had not been released at that time. And you can already tell that the right atrial disc has already passed on to the left side of the limbus, which is, to me, if you are doing the PFO closure, is an absolute no-no for many, many reasons, and we'll talk about this. And this device absolutely embolized, went to the LA, from LA to LV to ascending to descending thoracic aorta. This is the device in the descending thoracic aorta. It was retrieved subcutaneously, percutaneously by the operator here. So this device, without any question, I'm sure you know this, is embolized because the limbus never got covered. It's an absolutely necessary in a PFO type situation. The right disc covers the limbus, or the SV rim, and or the aortic rim for sure. And if it doesn't, since the PFO is like a slit, the right disc will get inside it. So two things will happen. If the device discs are big enough, it may not embolize, but it will then keep the primum, the septum secundum wide open, and it will increase the risk of residual shunting and future strokes. So now that if the mistakes have been made, what do you do? Well, say your prayers. You talk with Ram and Bhagwan and God, Allah, and everybody that he helps you take the device out and NPO the patient immediately. So if the first time I ever embolized a device in 2000, I think 3 or 4, and the sonographer, I was driving and the sonographer called me and I said, ask mom if she fed the baby. It was a small child baby. And she asked and mom said, no. I said, okay. I said, first thing was heparinize. I told the nurse to give her heparin there because the device was at that time in the left atrium. Because the device is moving in the left atrium, you don't know if some embolic phenomenon can occur, especially the smaller the patient. So I heparinized the patient in her room and then brought the patient in. And the patient was already NPO. You know what I'm saying? I called my staff, the surgical staff, gave them heads up, called the perfusionist and everybody, get ready. And then brought the patient to the hybrid lab. Jay gave general anesthesia, used a biplane lab, used a sheet. I prefer to use a sheet 3 French larger than 2. You know, people say 2 French risers. If you notice, I wrote more than 2 French. 3 French takes the device back out a little bit easier. Of course, that's a restriction if it's a smaller baby in so many ways, but you gotta do it what you gotta do, okay? If you have a bailout type device where if the sheath has kinked or something, it's not a bad idea. You can use different devices. The bailout system means the diameter of the device is as big or as thick as the cable is. You can use definitely several gooseneck snares. Amplast gooseneck snares are my favorites, and you can use end snares. There are multiple sizes you can choose based upon the device, and of course the sheath size as well. Some physicians do use bioptons. I don't like them sometimes because sometimes if you do grab a bite, you may grab a bite of any tissue. But I think they can be very good to stabilize the device if you were to retrieve it if it was really hypermobile. Of course, you need to have larger diameter Mullins sheets available. You can bevel the sheet, and I can show it to you in a second. So these are the bioptomes, and I don't need to preach to the choir here how to use these things. You know, most of these are absolutely all of you guys have seen and used. You know what the angulation of the gooseneck snare is and stuff like this. This is the torque view system. For the beveling, why we need to bevel, I'm sure you have gone through this, because the female screw is so long that when you pull on it, this will not get in, and this will end up destroying the tip of the device, and then the device will not come inside the sheath. And here you can see the sheath is bent after multiple trying to pull it inside the sheath. Not a good idea. So a lot of time if you bevel it, you take it out. The problem with beveling is that you make one edge of the device very pointy, and that means you can make it very traumatic. So most of the recommendations, usually we will want them is, if you bevel it up to 30 degrees, it has less chance of causing trauma while it increases overall circumference of the sheath, okay? Always try to snare, as again, I'm preaching to the choir, the female screw. Now, a lot of times the device is embolized to the pulmonary artery. The female screw is facing cephalad, distant to the second, third generation branch pulmonary arteries. You may want to put a pigtail catheter. You may want to put a balloon tip catheter beyond it up over the wire, and then inflate and pull it. So that will flip the device, and the female screw will face towards you. And when it faces towards you, then you're able to grab it. You're able to grab it and take it out. Again, if you're in the pulmonary artery, you need to try to capture the whole device in the pulmonary artery. You just cannot believe in God enough that I'm going to take the device out of the pulmonary artery through the valve, pulmonic, and the tricuspid, and all the chordal attachments, and pray that it won't hurt anything. It has, and people have described it. Sometimes you're lucky, it may not, but you are better off actually trying to grasp all the device into the pulmonary artery. The easiest place is left atrium, of course, no question about it. Now, if you cannot completely recapture the device, you can pull it all the way into the femoral vein and then do a cut down. Okay, very, very simple cut down. Open the pulmonary, the femoral vein, and then take the device out. Okay. But most important is know your limits. Know absolutely your limits. That's where a lot of people make mistake. This is a publication for somebody in Mumbai, I think. I don't remember his name. I don't know if BD something is initials. Bharat, somebody named Bharat Dalvi, I think. Probably you guys may not know him either. Maybe Satya knows him. Yeah. So this is a publication, and I think this is a nifty technique. I mean, there is how to recapture the device. So Dr. Dalvi went from the neck as well. And I think that absolutely will help in device stability for you to grab it. I think this is technique to keep remembering, to remember that you have other ways to access it. Okay, so I keep everything. This is one of the, actually, believe it or not, this is my case. This was the first case ever. Was about 18-kilogram baby where I embolized this device, I think in 2004. As you can see how big this device is, it's almost half the size of it was an 18 millimeter device, and I undersized it by about 3 millimeters so it would fit in that tiny child, but it did not. did not. So I took it out and then put a 22 device in and send her home the day after. So here we see, if you can see, here we see we are able to grab it in the left atrium. We are going to pull it down. Sorry, can you still see it?
No, you have escaped out of it.
Yeah, I'm going to come back to it. Sorry, I don't know. Honestly, do not know what happened. So anyway, we were able to then pull it into the IVC and then put a larger sheath, take it out, and with the same sheath, we then put a larger, larger device in the atrial septal defect. Here you go. This is in the IVC. As you can see, we have pulled it in and took it out. So RA and LV device embolizations could be difficult. LV, you can take it out, but significant arrhythmias, a lot of chance of causing injury to the mitral valve, and that's to be an absolute no-no. Same for the right ventricle side too. This device on the right side was retrieved percutaneously. God, bless America. I don't know why it's doing this. Okay, so I do not know why it's doing.
I think maybe some network issue also, sir.
Yeah, but I don't know. But anyway, we are almost done. So the last thing, so LV, be cognizant. You know what I'm saying? You know what I'm saying? We may have to put him on bypass and then do this. And then there's the last thing is Jay. Jay, I know you know Jay Young from Korea. He described this double snare technique to remove the device, which I thought is a nifty. This is if you don't want to enlarge or don't want to bevel the sheath, you can use a double snare technique. Here, you can use double snare technique. You can use a second snare. You can put snare from the two snares from the sheath and hold the female screw at two ends. So when you pull on one and push on the other one, it tends to straighten the snare, and then it's a lot easier for the snare. Just like in this picture, as you see, he was kind enough to send this to me last year. And what it does is it makes it parallel to the opening of the sheath, and then the device comes in. Okay, there is a PFM multi-snare with 4 French things. So this is, I think, another technique that you can use, and he has taken out a lot of double disc self-centering devices and non-self-centering devices such as Gore device with it. So in my conclusion, I think one very important thing is you have to know what are the characteristics of the device you plan to use. The incidence of device embolization is low. Without an equation, I think it remains less than 1%, to be honest with you. But I think we can further minimize it to make it 1 in 1,000, if you will. A majority of the device you can retrieve by transcatheter techniques. But most important thing is keep patient safety. Main concern, not your ego. So know when to quit. Device does not interfere with blood circulation. That's a very important thing, because it's such the weight of the device is so low that it tends to the disc become parallel to the blood flow. Most of the time, that when it does not tend to stop the blood flow in the tricuspid, if you will, or the pulmonic, if you will, or the LVOT tract. There's only one case that I'm aware of, which in the United States, where the device went across the LVOT, and they did not notice it. It partially obstructed the aorta and ultimately actually caused injury to the aortic valve. It was a huge lawsuit, actually, believe it or not. So, and again, that tells you they did not look at this stupid device for a week. Patient kept complaining, but they did not even do an echo. So I think vigilance, thinking that what can potentially go wrong is also very, very important. And with that, I finish my presentation. Thank you.
Thanks, Zahid, for giving us this overview of device embolization and how to go about. So before I open up the talk for discussion, let me first welcome Varakan, who has joined us from Bangkok, and many other guests who have joined us from Turkey and other South Asian countries. So welcome to this learn from the masters. But when it comes to complications, complications don't differentiate masters and students. All are in the same boat. And so it's like learning from each other as far as complications are concerned. So I think we'll open up this paper for discussion. Shiva, if you have any questions or comments, you can please go ahead. Can't hear you. Oh, just a minute. Satya, you need to unmute Shiva.
Yeah, I'm unmuting.
Okay.
Yeah.
It's a dangerous thing.
Go ahead.
It is always a pleasure to listen to Dr. Zahid, and I was like enjoying every bit of his talk. Quite informative and lots of finer tips. Thanks a lot, Dr. Zahid.
Zahid, my question to you is, how often have you failed in retrieving your device in the cath lab and had to send the kid to the operating room?
So, I've been called me lucky. There's one patient I sent to the OR, brought him to the OR for one reason, and that was that I knew I cannot put a bigger device in. And I knew that it will not work. Other than that, I have been very lucky so far. You know what I'm saying? That I've been able to retrieve device from the RV, from the PA, from LA, you know, and from the right atrium. That one patient, I had to bring him to the OR was for one main reason, because there was no way we could close this defect, and the parents absolutely did not want the scar on the sternum. And so we told them, I said, the risk is very, very high. It may not work. You know, the patient had absolute absence of the IV serum. So that's, other than that, we have been very, very lucky. But again, you know what I'm saying? They say,
so let me put a question a little differently. You have been lucky, or maybe that you are accomplished, that you can retrieve most of the devices. But for the people in the audience, which are the cases where you will not be very aggressive in retrieving these devices in the cath lab, but would be happy to hand them over to the surgeons before you cause more trauma or more damage to the patient?
Okay, yeah, I would say, see the, I would say left ventricle. If the device somehow is big enough that it cannot get out of the LVOT, you know, if it's in the aorta somewhere, then it's really, really easy to get it out. As long as the patient is not too small and you won't cause injury to the femoral artery. It's very easy. But in the left ventricle, you will have very hard time taking the device out, because patient has so much ventricular activity. Blood pressure continues to change, very variability. And there's almost always, I know there is mitral, as you know, anatomically, there's a mitral valve arcade in a way that the way it is that the device has a very larger device, a very difficult time to go under the mitral valve chordae, but they do. Without any question, one of the edge will go into, and then it can get partially stuck, especially from the female screw into the mitral valve. That to me is the strongest reason to operate and take this device out. You
so
don't
why
want
are you partial to the LV? The device can get impacted into the right ventricle underneath the tricuspid valve.
And then also same thing. But absolutely, if you think that you have grabbed the device without, let's say with a snare, female screw, and when you try to pull it gently, it doesn't come out, and echo tells you that there's change in the tricuspid valve anatomy, TR increases or it partially closes at that time, so it means the tricuspid valve is involved. So maybe mitral or tricuspid valve, then you should not take that. Absolutely, you should not become.
There is one question, Zahid, from Dr. Dheeraj Kumar, who has asked you, do you have any experience of keeping the wire across the tricuspid valve to stent it to push the device from the right ventricle across the tricuspid valve into the right atrium, which is a more stable chamber to retrieve the device from.
So say that again, if you don't mind.
A few
wire
years
across.
back, we had described this technique of keeping the wire across the tricuspid valve, trying to stent the tricuspid valve and cause some ectopics in the right ventricle, some AV dissociation, so that the device gets flung into the right atrium across the tricuspid valve. So his question is that anything of that sort would be really useful in dislodging the device from the right ventricle.
I would say sounds pretty nifty to me, to be honest with you. Personally speaking, I have not done it.
Right.
You know what I'm saying? But if it works, hey, why not?
Another question is from Dr. Arun Bableshwar. He wants to know whether you have ever tried screwing the hub back into the cable and retrieving the device.
Yes. So I showed you the case. Unfortunately, remember the computer died on twice. In that particular case, we actually screwed on the device to the female, the cable to the female screw, and then we're able to very gently. So yes, we have done that several times actually.
Nageshwar, welcome to this meeting. Can you unmute Nageshwar if he has any questions for Zahid?
Yeah, I've unmuted Nageshwar sir and Vorakan sir also.
Nageshwar, do you have any questions for Zahid? I'm not sure whether he...
Yeah.
Oh, here is Vorakan. Vorakan, you have any questions for Zahid?
Hi, Bharat and Zahid. Really glad to seeing you both again, and also Shua. Yes, I missed the first part of your talks, unfortunately, Zahid. But just to share with you, I have 5 embolized case myself. Sorry for that, but that was about almost 10 years now. Hopefully that it won't happen again. Just to share that all of the cases I had actually similar to what Zahid mentioned, that deficient IVC rim, and that's the major issue. So initially I tried to tackle that with bigger device, but eventually it didn't work. So all of them I asked the surgeon to do for myself. I didn't try to recapturing it. But just one case that unfortunately I helped my friend to do that because it embolized to the aorta. So with that, it's very difficult for the surgeon to do. So that's why we decided to take it out from the femoral arteries. So my philosophy is, if it's in the place that the surgeon can do, and the device is too big, I think it's better to ask a surgeon to do. But if it's very difficult for them to help me, I may try my best to take it out. So that's just sharing.
I think that is very, very important when to stop. Don't let the patient get very sick before you send him to the theater. Otherwise, he'll get sicker, and you may ultimately end up with really an adverse outcome. One last question, Zahid, before we go on to the next talk, is from Dr. Usha, who has asked you, how safe is it to put a 14 French sheath in a 20 kg child? And I presume this is a 14 French through the vein.
Okay. So what I think, as you know, if you have a newborn baby and you want to do balloon septostomy, you can put a 7 French sheath in a 2.5 kilo baby, right? So the veins are very distensible. So what we do in situations like this is we do sequential dilation of the vein. We are not going to go with a 14 sheath right from the get-go. We are going to do sequential dilation. Let's say if the patient had an 8 French sheath, we are going to use 10, 12, and a 14, and then a 16 dilator first. So we actually stretch the diseases of the vein and then put a 14 French sheath. So in a 20 kilo child, 14 French sheath is totally fine, to be honest with you. Okay, the only thing I could tell you is there was one time I could not do a Melody valve case. I could not put an 18 sheath in a about 18 kilo child. but I was able to stent the RVOT with a 16 sheath, but 18 absolutely would not go. So sometimes you could have issues with it, but 14 sheath you can definitely. But you do sequential dilation. Do not just shove the large sheath in, because then you definitely have a chance of hurting it. But if you use larger, in the last dilator you want to use has to be bigger than the sheath you plan to use. Use a 16 dilator. Remember, the sheath is about a French and a half to 2 French larger than the dilator, right? So if you want to put a 18 sheath, for example, you need to put a 20 dilator. If you want to put a 14 sheath, you need to put a 16 dilator to make it bigger.
So I think I will just conclude this session by one or two concluding remarks. One thing you have to remember is that when you have more than one risk factor, the chances of embolization are very high. And what are the risk factors? One is the size of the defect. Second is the rim deficiencies, and that too in multiple planes. If you have rim malalignment, and if you have floppiness of rim. So each of these is a risk factor for embolization. And if you have more than one, then the chances go up exponentially. So you have to be very careful taking this patient into the cath lab and how well you counsel the families. Do that before the patient is on the table and not after you embolize the device. The second important thing is that the commonest cause of embolization, as far as not the defect characteristics are concerned, but as far as the operator is concerned, I think undersizing the device is one of the commonest cause, because there is always a fear of erosion. So it's erosion versus embolization when it comes to sizing. The second is use of softer device. It is a trade-off. Again, for preventing erosion, if you use softer device, the chances of embolization may be a little higher. And remember, when you are on your learning curve, improper placement of the device is another important cause for embolization. So be 100% sure on your transesophageal imaging that all the rims are adequately caught. If there is any doubt, don't release, hoping against hope that this device is properly caught, especially the IVC rim.
Correct.
Many times when you place the device, you will find that the imaging really becomes bad on transesophageal echo. So give some time for good images. And only after you are convinced that all rims are adequately caught, that you should release. Once the device embolizes, always retrieve the device from areas where there are no structures to damage, like the atria and the great arteries. Right atrium, pulmonary artery, left atrium and aorta are the safest. And as Zahid said, LV and RV are the most difficult areas to retrieve. Lastly, don't pull the device across the valves if it is not covered by sheath. You may get away with it, but there is a good chance that you will traumatize. And lastly, when you have the patient with embolization, know your limitations and stop well in advance before you make the patient sicker. So with that, I will conclude this first session and we will move on to the next session. So the next talk is, I think, my talk on the Indian perspective. I'll take 15 minutes and complete the talk. So can you hear me, guys?
Yes, and we can see the screen.
Yes, we can.
Okay. So the title of my talk is Retrieving Embolized Devices, the Indian Perspective. The thing is, embolized device is an embolized device. Whether you embolize in the US or in India or in Japan or in Australia, what difference? And truly there is no difference. All the principles of retrieval remain the same as far as the device embolization is concerned. And that's why I endorse most of the views that have been expressed by Dr. Amin. So what is unique to India? And the most important thing is that all our cath labs are not adequately stocked. And the availability of the hardware is always an issue. So before you take up a patient of ASD, be sure that you have all the hardware, the inventory is complete in terms of retrieval devices and in terms of delivery sheets. The second important thing is availability of the operating room. Sometimes if the operating room is busy, you may have no choice but to just twiddle your thumb because you did not have the place in the operating room, and the patient can get unstable, especially if he has ventricular arrhythmias. And most importantly, availability of a competent surgeon, because all these retrievals are not technically easy. Some of them are, but some of them really require some amount of technical expertise. Another important thing that is unique to India and other developing economies is the fact that in our environment, failure is not an option, and complication is even worse, because complication costs, not only in terms of morbidity and rarely in terms of mortality, but monetarily, it is very expensive. And that is what we can't afford in the countries with limited resources. These are some of the things which I have discussed with you last week, but I thought I must emphasize these things because they are so very critical in dealing with complications. Complications don't knock before coming. They come as a bolt from the blue. And that is why alertness to recognize and preparedness to deal with them are the two most important qualities of an interventionist. And when you are training yourself, please see to it that you acquire these qualities sooner than later. Equally important is the art of communication. Believe me, apart from your technical expertise, it is important how well you communicate with the family. Unfortunately, in India, it is neither a part of our curriculum nor the part of evaluation of any exam system. And that is why we have to learn it on our own. You are lucky if you have a good peer from whom you can learn this art of communication. Most of the medico-legal issues are because of improper communication, or more often because of lack of communication. So you have to be very careful. Now, this is another important thing which is unique to India. Here, apart from playing a role of a physician, you are expected to play God. So when you try and explain to the family as to why I want to intervene, they will say, ki sir, aapko jo karna hai wo karo. When you try and explain to them why surgery and why not intervention, or why intervention and why not surgery, sir, aapko jo sahi lagta hai wo hi karo. If you try and explain to them as to why I want to intervene now and why not later, something like an emergency or urgency versus elective, again they will tell you the same thing, sir, hamare liye aap Bhagwan hai, jaisa chahiye waisa karo. So what happens when you hear this from morning to evening, you actually think that you have become God. It is important to realize that you are not one and that you are going to face complications. So remain grounded. And every time when you counsel, never tell them this is 100%, because there is nothing like 100% success. And lastly, when you counsel the family in distress, remember a few principles. Do it yourself, preferably. If you are too busy managing complications, send the second person in command. Explain to the family the sequence of events as they occurred. Also tell them what has already been done and outline the plan as to what you are going to do in future. Be honest and be positive. Listen to the family patiently. Some of them are quite aggressive. Some of them can be abusive, but you need to be patient. You can neither afford to be aggressive and certainly not abusive, being a physician yourself. Lastly, be matter-of-factly, but don't be indifferent, because empathy is the rule of the game. When the family is in distress, you need to be empathetic. So with this brief introduction, I'm going to share with you some of our experience of VSD device embolization. Fortunately, it's a rare complication and in our experience, less than 1%, but it can have serious consequences. As you know, VSD device can embolize both on pulmonary side as well as on the systemic side. And it can be dealt with in both ways. You can deal with it in the cath lab or in the operating room when you have failed in the cath lab, or you think that something that cannot be achieved in the cath lab, and send the patient to surgery prophylactically. So this is the first case, a 9-year-old child weighing 30 kg with a perimembranous VSD, asymptomatic, but hemodynamically significant left to right shunt. ECG in this child was unremarkable. X-ray shows normal heart size, little pulmonary artery prominence, and vascularity marginally more than normal. This is a a small perimembranous VSD, but hemodynamically significant, as you can see here. And there is a significant left to right shunt. So this is in very early part of our experience, maybe 2008 or 2009 maybe. And what you see here is that there is an aortic regurgitation. You can see that. And in the parasternal view, you will see that there is a definite aortic valve prolapse and aortic regurgitation. Probably we were not wise at that time. And I thought that maybe this is a good case. Apart from closing the VSD, maybe I'll be able to support the aortic valve and prevent the progression of the aortic regurgitation. With that purpose, this patient was taken up for device closure. This is a transesophageal echo. The quality is not the best. This was not the best of the the transesophageal probe, and this was 11, 12 years back. So you can see here that there is a left to right shunt, and you can see that there is a prolapse of the aortic valve here. So despite this, we thought that we could probably close this in the cath lab. And this was an era where Emplar's asymmetric perimembranous VSD occluder was still available. And given the fact that aortic valve was prolapsing, the defect was close to the aortic valve, we decided to use this particular device for closure. So this is an angiogram which shows you a small defect there. Although the anatomical defect was bigger because of the prolapsed valve, the functional defect was not too big. But if you see the left ventricular size, definitely it looks voluminous. And this is the aortic root angiogram, which was routine in those days to show the deformity of the right coronary cusp there. So we made an AV loop and got the sheath into the left ventricular apex, and then delivered the left ventricular disc and made an angiogram to confirm the position of the LV disc. Once we were happy with the position of the LV disc, we released the waist and the RV disc, and again confirmed that the position was absolutely ideal. Then we did the aortic root angiogram to confirm that aortic regurgitation certainly had not progressed much from the baseline, and so we thought that it was good for us to release, and hence the device was released and looked pretty good. I think apart from a little bit of foaming here, the device looked probably in optimum position. And these are some of the transesophageal pictures. The LV disc is on the LV side, RV is on the RV side, a little bit of foaming across the defect, but nothing coming around the defect. So we were quite happy. And this is in the long axis equivalent view, which shows you the device sitting underneath the aortic valve, supporting the aortic valve beautifully. And this is the colored image, which shows that there is a little bit of foaming, but device is pretty stable. Now, what happens at 4 o'clock, this is early, this is in the morning, maybe around 11:30. The fellow on duty hears a systolic murmur. There was no event that was recorded, any hemodynamic instability or any arrhythmia. The vitals were normal, saturations were good. But when you hear a systolic murmur in somebody who has undergone a VSD closure, I think the diagnosis is obvious, which was confirmed by echo, that the device has embolized. And you can see the device on the X-ray, probably in the left pulmonary artery. So the options are always remove the device or leave it there, whether the removal should be transcatheter or surgical. So we took the patient to the cath lab under general anesthesia, and you can see that the device is sitting just at the origin of the left pulmonary artery, or just inside there. And you can see here that the device is so located that it is not compromising significantly the perfusion of the left lung. But we decided that rather than keeping it here, we should give it a shot and remove this device. The thing is, these are some of the issues, that what sheath you are going to use, how are you going to rotate the device, because the screw was facing the wrong side. It was towards the lung and not towards the pulmonary artery end. How will you hold the screw? Again, bioptome, or you're going to use a snare or a combination or what have you. And if you can't hold the screw, do you have any alternative strategy? Because even a screw of the VSD device is not very easy to hold, unlike a ASD device where the screw is far more superficial. So the first principle was to turn this device in such a way that the screw starts facing towards the pulmonary artery end and not towards the lateral chest wall. So we went with a guide wire distal to the device, and then we had the sheath here, and then we have this catheter of the snare which is distal to the device. Then we got the snare and turned the device. And you can see now the device is turned and the screw is facing medially, that is in the right direction. So we decided that we'll keep this snare here to stabilize the device and come with another snare to try and see if I can grab the screw. But believe me, it's not very easy to grab these screws. Although if you maybe try multiple times, you may be lucky sometimes. But this day we were not so lucky so as to grab the device, grab the screw. But we were able to grab the device and we could partially get the device into the sheath. And not the best principle of retrieval, as I said, but with a partial grabbing, we could come across the pulmonary and the tricuspid valve. Ideally, it should be complete grabbing of the device inside the sheath. But we were lucky and we could get into the IVC without damaging the pulmonary and the tricuspid valve. And then we came into the femoral vein. Here, we stabilized the device with a finger. And then we got the surgeon operate, kept the balloon from the opposite side in case the surgeon, while manipulating the device, again goes back. This scar looks a little ugly after 2 or 3 days, but believe me, after a couple of months when I saw this girl, this was a good scar. And then she went for a surgical closure of the VST. So the lessons learned: in presence of the aortic valve prolapse, there is a good chance that you might undersize the defect. So you might have to oversize the device a little bit. When the defect is subaortic and extends more anteriorly and superiorly, there is a chance that there is no adequate support from above. And so with the combination of these two, we believe that this was a poor case selection and maybe even a poor device selection. While removing the device, I think I could have upsized the sheath a little more than what I did and would have been able to get the device in a squeezed manner inside the sheath, but that didn't happen. And most importantly, you need a good surgical support, not only to remove the devices from within the cardiovascular system centrally, but sometimes peripherally, as was done in this case. Let me go on to the second case quickly. This is a 5-year-old, again, a symptomatic child who had repeated respiratory tract infection, 2 hospitalization, and significant failure to thrive. Had a moderate-sized perimembranous VSD with left atrial and left ventricular volume overload. She was taken for device closure under general anesthesia with TE and TT guidance. And I think we went the right way. This, you will agree with me that this is a moderate size defect showing LA-LV volume overload. Again, an arteriovenous loop, got the sheath into the left ventricular apex, decided to use an 8x6 ADO1, and then we got the aortic end or the LV end towards the septum, made an angiogram, and I think I was very happy with the position of the aortic disc. So we released the pulmonary end of the device, and the device seems to be sitting pretty good. So we made an angiogram, as you can see here, and it looked good apart from a little bit of foaming. And then, we were just did a little bit of tugging of the device and looked good. So we decided to release the device, and the device is released now. And you can see here that apart from a little bit of foaming, I don't think that the device is badly located. Only one point you have to see. Look at the thickness of this interventricular septum. And this is something we have realized, that when you have a thickness like this and when the device sits on the crest of the interventricular septum, I think if there is no surrounding tissue like a well-formed aneurysm, this device may not be stable. Now, I don't know whether it was the stability of the device, but while I was pulling the pigtail, I think I dragged this device. Maybe it would have embolized anyway, but I dragged it into the ascending aorta. And so the famous saying that it is not over till such time it is over. So despite everything, I think we managed to create this complication. Then we started with a snare coming from the venous side so we can make use of a little larger sheath. But as I said, and as Zahid said, this ADO, the screw is right inside. 6x4 is the most difficult, but believe me, 8x6 is not easy at all. Then we tried with some other grabbing devices, some other snares, but we were unsuccessful. Subsequently, we were able to grab the device with a micro snare. You can see this. But micro snare just doesn't have the strength of slenderizing the device. So even if you are able to grab the screw, as was done in this particular case, you can see I have grabbed the screw with a micro snare, but I am not able to slenderize. The moment I make an attempt, the device just gets out of the snare. You can see that. So this is the device I'm trying to slenderize, and the micro snare comes off. See that? And the device is back in the position. So what to do then? So we tried to grab the screw on the pulmonary end, but it's not easy to grab the screw with a bioptome either. As a matter of fact, we had one experience of grabbing the aortic end of the screw with a bioptome, and that is what we did. We got the device the other way around, and we were able to get hold of the screw on the aortic end, and we were able to get the device. Unfortunately, the device came just partly inside, but not fully. But that was not difficult. We could grab it again with a bioptome and then got it down. What we realized is that probably this was not the size issue, but this was the type of the device that we chose. Or maybe it was just the problem with the pigtail catheter dragging the device. But next time I did not have the guts of using the ADO1. You can see in this angiogram, look at the thickness of this interventricular septum. So I decided to use a double disc device like a muscular VSD device, same size, that is the 8 millimeter. And this is the final angiogram. This was done after 4 or 5 months of embolization, because there was no urgency to close the device in the same sitting, close the defect in the same sitting. And this is the last case that I want to show. So the lessons learned is that you need to give attention to the minutest details. So while removing the pigtail, you have to see that your wire is across, you have slenderized, you have undid the pigtail before you remove. Otherwise, the costs are substantial. Maybe wrong choice of the device, as I said. Maybe double disc would have been better than using ADO1. As I said, ADO1 is a difficult device to retrieve because the screw is right inside, and micro snare may be able to grab the screw but does not have the strength of slenderizing the device. So it is as good as being useless. Holding the aortic screw and doing what I call as a reverse slenderization may not be a bad idea. So now we go on to the next case, and that is the last case. This is a very small case. This is not my case. I have borrowed it from my friend. This is a small muscular VSD, but patient was symptomatic, and they thought that this was a hemodynamically significant shunt. It was, you can see the way this defect is. It has a serpiginous course inside the interventricular septum. It arises at one point on the LV and exits at another point on the RV. So it was decided to close this defect using a muscular VSD device. And you can see that the LV disc is here, and then the waist and the RV disc. Many times when the device is on the loading cable, the RV disc may not form itself well. So it is not an uncommon thing, but given the fact that this defect had a serpiginous course, it was not a great idea not to form the RV disc before it was released. However, the operators thought that the RV disc will form itself once they release it, so they released the device, hoping against hope. And look at the angiogram. That angiogram shows well-placed LV disc, and the device also looks adequate, and that there is no residual shunt. After 15 minutes again, the device looks good, but again, there is no formation of the RV disc. And what actually happened, this end was never in the RV. It was in that tunnel within the interventricular septum. So 20 minutes later, the device is in the left ventricle, and this patient had to go for surgical retrieval. So one case, hybrid retrieval. Second case, full retrieval in the cath lab and closure of the defect in the cath lab in second sitting. And third case, where you have retrieval entirely in the operating room, and the defect was also closed in the same sitting. So probably in the last case, we used a wrong device. We should have used a device which elongates itself, like ADO2 or a PFM coil. Never release the device unless you are sure that one disc is on the left side and one disc is on the right side. There is no scope for being super optimistic that after you release the device, it will form itself, because by that time it is too late. If the device is stable in the LV underneath the mitral valve apparatus, trying to withdraw it in the cath lab, retrieve it, may be technically challenging. and that's why better to send this patient when he's stable to the operating room. Surgical removal is never a bad idea. So I will summarize by saying what appears simple is not all that simple, and there is nothing like a slam dunk in interventions, whether it is device closure, whether it is valvuloplasty, whether it is a fistula closure or what have you. Thanks for your patient hearing, ladies and gentlemen. And if you have any questions, I will be more than happy to take.
Can I make a comment, Bharat?
Surely.
Yeah, that was a great presentation. I think the second case, straight away I would have gone for the double disc because there was a septal aneurysm. Whenever septal aneurysm is there,
right,
your duct occluder doesn't sit properly. So
correct.
the double disc is better. And regarding the third case, the RV side, the deformed disc, it shows that either it is in the hypertrophic band or caudate,
right,
spot, and that's the reason it is deformed. So I have also learned, fortunately, I must say I'm a blessed soul, unlike both Zahid and you. I have never had AST or VST embolized, only PDA devices have embolized. But I think the deformed disc indicates that there is something wrong.
Okay. So I have a few questions. One is from Dr. Muthukumar. He says that if you are planning surgery, why can't send the child straight for surgery? I completely agree with you, Muthu. I think you are talking about the case which got embolized into the left pulmonary artery, because we were going to send that child for surgery. There were two reasons. One is that this patient had aortic valve prolapse with aortic regurg and we had embolized. So we were not going to attempt this child, but his device was a little distal. And maybe that surgeon might have got it in that position in the left pulmonary artery, but it was near the bifurcation, might have struggled. And maybe it is possible that device could have moved even further distally. That is why we attempted. But this point is well taken. If you have made up your mind to send the patient for surgery, there is no reason to send this patient to the cath lab, subject the patient to irradiation and so much of cost in getting the device up. The only other reason why you can do it is if you don't have availability of the operating room or the surgeon, which cannot be an excuse. So that point is well taken. The second question from Dheeraj Kumar, could you have used a snare from the jugular root to slenderize the device so that it could have been taken into the sheath completely? See, this was a small device and I did not have the courage of releasing that device somewhere in the IVC and try and see whether I can stabilize from the jugular vein, if I understand your question correctly. But otherwise, the principle that holding the device at two ends in order to slenderize it is, I think, perfect. But in all cases, you are not so well planned so as to have one more access from the jugular vein or from the contralateral femoral vein so as to hold the device from both ends before slenderizing. But I take your point that holding the device at both ends from point of view of slenderization is always a great idea. The next question is, would a double disc device have prevented dislodgement? That question is discussed, and as Vijayalakshmi said, that maybe if you don't have a good aneurysmal tissue, we thought that it was not too bad and we made a mistake, burnt our fingers. Next time came with a double disc device and it was good. For VSD and PDA, rescrewing should be the first attempt. Is it true? I agree with you that rescrewing is not a bad idea, especially if the device is in the aorta. I think trying to get duct occluder out with a snare, I think is a bad idea. Snaring a duct occluder is very difficult. So if your duct occluder is facing towards the pulmonary artery, the pulmonary end is facing towards the femoral artery, best thing is try to rescrew. And I think there are subsequent cases, the operators will show how they have successfully rescrewed the devices in the descending aorta. That's a good idea. But if the aortic end is facing the femoral artery, it's not a bad idea to use a bioptome, grab the aortic end and reverse reslenderization of the device. We have done it on more than one occasion successfully.
Bharat sir, Dr. Amin has a question.
Please go ahead.
All right.
Go ahead.
Can you hear me?
Yes.
Can you hear me? Hey, tell me the role of moderator band, in your opinion. Role of moderator band in, because as you know that the waist gets elongated, the right disc may not form. And I think you have one case, and I have one case where the right disc didn't form, and over time, it actually squeezes out into the left ventricle.
Yeah.
So the role of moderator band, when would you be comfortable looking at the right-sided disc and say, okay, this is stable enough? Because it's very difficult to tell.
I agree with you. After having seen this case, Zahid, I have made it a policy that unless the RV disc is well formed, usually when the device is, when the defect is close to the moderator band, many times we come from the jugular. I will keep pushing on the loading cable till such time the RV disc is beautifully formed, and then confirm on echo and angio, and only then I will release. Having seen this case, I'm always scared that ill-formed RV disc can be a harbinger for device embolization onto the left ventricle. And I don't want to burn my fingers again. Vijayalakshmi, I'll give you a chance. I will just take another couple of questions from the audience and then you can come in. What was the indication for closure in this patient? I don't know which patient, but all the patients were symptomatic. And believe me, the last patient, not the muscular VSD, because muscular VSD is not my patient. So I don't know the exact symptomatic status and why that patient was attempted. But the first two patients were both significant and both had hemodynamically significant shunts. But then this is a question from Dr. Tong. May I know the longest procedure time for retrieval? I think there are no hard and fast rules, but in our practice, usually if we exceed maybe a couple of hours, we are not very comfortable, then keep on trying and trying. Unless we feel patient is hemodynamically significant and we have some other trick up our sleeve. Trying the same thing over and over again, if it has failed 2, 3, 4 times, doesn't make too much sense. So it's always better to give the patient to the surgeons. Vijayalakshmi, last question before we proceed on to the next speakers. Go ahead. I can't hear you. You will have to come closer to the mic. Can't hear you. Satya, have you unmuted her?
Yes, sir. Yes, sir. Ma'am,
your speaker is not working. Vijayalakshmi, your speaker is not working.
Can you move a bit closer to the system?
Yeah.
Yeah, it's better now.
Zahid said.
No, can't hear. Can't hear. Can't hear.
Ma'am, can you text me that question? Like I'll send it.
Varakan has a question. We can't hear Vijayalakshmi.
Dr. Bharat, when Dr. Vijayalakshmi is typing the question, I just have one instance that I wanted to share. There was a patient with an ASD device which got embolized into the aorta, and finally we snared it down up to the iliac artery. And at the level of iliac artery, then the child was too small that we did not want to take it out. The decision was to give it to the surgeon to do an iliac artery cut down and take it out.
Correct.
At the time, the thought process was the patient has to, for a closure of an ASD, he has to go on cardiopulmonary bypass and on full heparinization, whereas for exploring the iliac artery, minimal doses of heparin is needed only after the arteriotomy is being made.
Correct.
So we decided to close the ASD with an embolized device that is sitting in the iliac artery, close the ASD, and then subsequently told the surgeon to go only for the retroiliac, dissection. So there will be sometimes decisions will have to be individualized. When I was looking at the question that was asked to you about why, if the device has embolized, why not you send for surgery? If you can retrieve it into a place where the surgeon can do something minimally invasive rather than going on full cardiopulmonary bypass, that may be a role.
Absolutely. I take your point on that. But here, as it is, the patient was going to go for surgery. But as you very rightly said, you may have to modify strategies depending upon the situation. And sometimes you may have to do it in a hybrid way, that you do one part of the thing and the second part of the thing is done by the surgeon. So if you can close the ASD in the cath lab, then you can close it with the larger device and let the device in the iliac be retrieved by the surgeon. But in our case, since we had already made the decision that that VSD we are not going to attempt again with the size of the VSD and the prolapse of the aortic valve, maybe we could have given that to the surgeon. But I think your experience is well noted and I think makes sense.
Yeah, Dr. Vijayalakshmi, I think she's ready with the question, madam. I think we lost her.
Varakan, do you have any questions? No. Okay. So I think we will move on to the next talk. Satya, you will have to call the next speaker and tell them what are the guidelines.
Yeah. Next speaker we have is Vijayalakshmi ma'am. I think but in her video and the audio, I think there is some trouble.
So let's go to the next speaker, please.
Yeah, that's Dr. Rohit Manoj.
Rohit, go ahead. Good evening to you.
Sir, 1 second. Yeah.
Can you hear me?
Yes,
Yes.
I can hear you, but you'll have to share your screen with us.
Yeah.
Rohit is a professor of cardiology at the Postgraduate Institute in Chandighad and runs a pediatric cardiology program there for a number of years. He's a very accomplished interventionist, and he'll present his cases of device embolization. Go ahead.
Can you see my screen?
No, I can't.
Not yet, sir. Sir, you need to share the screen.
Mm,
On the bottom of the Zoom window.
sorry.
Come down with your pointer, with your these things to the bottom of the screen, and there is a green button there, share screen. Press on that.
Just अंदर क्या हो गया?
Sir, just move your cursor.
No, I just blanked out my screen.
Okay.
So,
You can.
sorry.
Satya, Dr. Supratim is ready.
Yes. Yes. Yeah.
So let Supratim present and let Manoj figure out how to share the screen. Let Supratim go ahead.
Right, sir. I have unmuted user.
Can you see my screen now?
Yes.
And am I audible?
Yes, you are audible, but come closer to the mic because you're soft-spoken. You need to speak a little louder.
Good afternoon, everyone. And thank you for allowing me to show my cases. So I'll be talking about PDA device, some different retrieval strategies. So this first case was a 15-month-old child weighing 8 kilograms. And you can see on the initial angiogram that the pulmonary end was a little tubular. This measured around 2 millimeters. We thought this would be fine for a 6-4 device. We used a 6-4 Lifetech Serra device. And this is the angiogram after the device is deployed. It looked pretty good. There's a good flaring of the pulmonary end. There's a good waist. And when we released, if you look carefully, there's a big ricochet here, which obviously is not desirable. And as soon as it ricochets, the flaring also is not as prominent. We did an angio here, and now the pulmonary end of the device isn't splaying as much as we would like. The waist is still there, but probably should have been a bit better. But the device was still in position, so we were hopeful this would be all right. But unfortunately, it embolized about 2 hours later. So we again crossed the PDA from the venous side. We put in a 7 French Mullins sheath. And initially, we were trying to snare it out. This is with a 10 millimeter gooseneck snare. But the device kept getting pushed lower down into the descending aorta. So then we came from the arterial side with a pigtail to support the device. And finally, we were able to get a hold of it, and we could cylinderize this back into the sheath. So once that was done, we came back with an 8.6 device, and we put the 8.6 device there. I don't have the post-release angiograms, but this was fine. The next patient was a 5-month-old child. This was a patient of Dr. Deepak Changlani's, who's one of my colleagues, and we did this case together. So the initial device closure was done with a 6-4 device, which was done only with a venous access. I don't have those angios with me, unfortunately. But again, about a couple of hours after the device closure and when the patient was in the recovery, we heard a murmur. And when we got this patient back to the cath lab, we could see that this device was sitting in the ampulla with the pulmonary end, obviously not across the pulmonary end of the PDA. So initially, again, we tried from the venous side. We went with the sheath and took a JR across that sheath. But this device was wedged into the descending aorta with the aortic end actually facing the snare. So we weren't getting a stable position here to snare this out. If you see on the lateral, we were getting close to the aortic knob, but we weren't getting a good position. And that's when Deepak suggested that why don't we try with screwing the delivery cable back on. We didn't want to put in the delivery cable through a large sheath. So we took a smaller ADO2 cable, and this has gone through a 5 French JR catheter, and then we screwed this back on. We couldn't slenderize the whole device back, but we were able to partially slenderize, and then we pulled this whole assembly into the 5 French groin sheath, and we could pull this out. And then we went back from the arterial side and put in a 6-4 ADO2 device. This is the last angio. And the last patient is courtesy Dr. Dalvi. This is one of his patients. This was a 6-month-old child, 5.5 kilograms. It was a type A PDA measuring 2.1 mm at the pulmonary end. And he put in a 6-4 PDA device. This is the still image of the PDA. You can see there's a good waste before the release, but this device unfortunately embolized about 12 hours after the procedure. So he tried from the venous end to cross the PDA, but you can see there's not enough space there to get a good position. He was then able to push the device lower down into the descending aorta, and he was able to snare it. But as you can see on the right angiogram, that there's a malalignment between the body of the device and the sheath. So although there's a good stable snaring of this device, he couldn't slenderize this back into the sheath. Now with the device held stably from the pulmonary end through the snare, he then went from the aortic side with the 5.5 French bioptome, and he caught hold of the aortic knob on the aortic side. And then this he could pull down through the aorta, and he could get it out of the groin sheath over here. So this, we published our case series here about different techniques to retrieve. And based on this experience, what we thought is, one, when you use a 6-4 device, especially a Serra device, it's a very soft device. So there's not much of a stenting force from the body of the device onto the surrounding PDA. So you have to be very sure that the distal pulmonary end is playing well into the pulmonary end of the PDA. And the second thing which we have changed is that we used to use the Lifetech delivery cable. And because it's a thicker cable, often when you unscrew it, there's quite a lot of recoil. So now we've started using the thinner AVP2 or ADO2 cables, even with Lifetech devices, especially the 6-4. And with these, the recoil is very less. And once you don't have a recoil, usually the device doesn't embolize. Thank you.
Thanks a lot, Dr. Supratim. That was wonderful. 3 patients that you presented in and retrievals in different methods. I'm finding in the chat box possibly one question. An embolized device very distally into the branch pulmonary arteries and not creating a larger area of avascularity. Can we leave it there alone? One question was there. I think it is very difficult to accept leaving behind a device in the lungs. Maybe there is an exception. If it is an extremely tiny 6-4 device in an adult who is 40 or 50 years and it has gone very deep into one of the segments. Otherwise, we would like to retrieve the device. Dr. Zahid, Amin, what is your opinion?
I agree with you. I completely. We should. Couple of things. I think I think these were 3 very intriguing and very different cases. The first case definitely appears to be a mind boggler, because the device appeared very much in proper position. So you beg to ask, maybe the PA pressures were elevated in that case, because the device was long enough that the tip was almost in the pulmonary artery part of it. So why would it embolize? The second case is definite embolization, because I think it was way too much into the aorta from my perspective. I'm very strong believer that all devices that embolize, they need to be taken out. You know, I agree with you that if you are absolutely bound and is an adult patient, then you shouldn't. But I have seen people who have embolized coarctation stents into the abdominal aorta, and then they don't go after it. They leave it alone, and the patient apparently is doing fine. But I think in smaller children, any device that has embolized into the PA or anywhere else, we don't know what type of scan issues this patient is going to have in the future. So I completely agree with you. I think it's a best practices would be to retrieve those devices. Just my first patient that Dr. Supratim Sen presented is a mind-boggler. I mean, why would device embolize in that particular situation? I don't know. Shiva, you have any, did you see the first case?
Yeah, Zahid, I think Dr. Supratim showed the patient well. While there was a small amount of pulmonary artery waste before he released the cable, the moment he released it, the long tubular PDA, the device got sort of sucked in, and there was no pulmonary artery anchor at all. Especially this is a problem when all the devices are only 7 millimeter in their length, and if the tubular PDA is much, much longer, say around 10 or 12 millimeter, very often the edge does not reach the pulmonary end. And that's one of the reasons why a tubular PDA is always an extremely tricky PDA.
Oh yeah. Well, you know, I mean, the problem here actually is now that we are doing premature babies here in the US very often, even as small as 650 grams. There, it's like a nightmare having a device embolized, because patients cannot go to the OR either. So usually you have to do a good job, if you will. Not that we do a bad job, you know what I'm saying? So for me, it has become a nightmare thinking about it if the device embolizes in those smaller babies. And those PDAs luckily are very, very long, and the device fits in them and what have you. Would you, if in a long PDA, Shiva, would you tend to then use a plug type device?
Yeah, depends on the age of the patient and depends on how much is the diameter. If it is a smaller PDA, like anything that is less than 5 or 6 millimeter, then something like a vascular plug 2 will be a good choice. But the same thing, if it is a 10 or 12 millimeter large tube, then the plug 2 does not have the inherent strength to withhold the force of the blood flow from the aorta to the pulmonary artery. And these are quite tricky ones.
So what would you do in a large PDA that is tubular and long then?
Yeah, actually,
if the ASD ADO doesn't work, plug doesn't work. So what would you recommend then? What would you recommend the younger population, younger physicians? What will be your mode of approaching that particular patient?
The same topic was discussed about a week ago as a topic at a session on large PDA device closure. In those cases, my view will be to go for an extremely large duct occluder device, which is like custom made. Like the Lifetech has got devices as large as 30-28 PDA devices. So choose one of them and try to put it intraductally, and sort of the device will not have any shape. It will be forming a ball, and it will be going and sitting. And we discussed a few cases like that. Like so, especially Dr. Zahid, there are certain geographic parts of our country as well as the neighboring countries. For example, whenever I go to Nepal, I find that because it's closer to Himalayas, those PDAs are extremely large. The same thing happens in Africa. In countries like Rwanda and all, which are at a higher altitude, and those PDAs will be like you will find patients walking around with 12-14 millimeter PDA, but still operable, sort of massive tubes. And in such cases, we have used some of these large, like very, very large PDA devices like 28-26 or 30-28, which are all completely unacceptable in USA by the FDA.
Okay, great, thank you.
Thanks a lot, Dr. Supratim. I think Dr. Manoj Kumar Rohit's slides are ready, and we look forward to hear from you, Dr. Manoj. Manoj, we are seeing your slides, but your audio is not on.
Yeah, I'm just unmuting, sir. 1 second. Yeah, yeah. No, sir.
Can you hear me, Shiva?
Yes, yes, very well.
Yeah. Good evening, Shiva, Bharat, Nagesh, all of you. All of you have taught me something somewhere down the line. So it's wonderful to be part of this symposium. I will try and show some 2-3 cases where I thought we often think that the procedure we know, we learn, it's a simple, and suddenly something goes wrong. So I'll just try and share the short experience of azygous continuation IBC PDA 4 cases. So we all know the azygous continuation. Either you could use jugular approach, or you could continue to do with azygous vein, or you could use muscular device. Various options are available to us. So this is the first case, a very simple PDA. Unfortunately, child had azygous continuation, so we had to use a normal. Fortunately, crossing was not at all difficult, and 8/6 Lifetech device was deployed successfully, and there was no problem at all. Similarly, this child had a dominantly azygous continuation, a very small right side vein. We were able to cross the Cook MPA catheter to the right side, and there is no loop. You can see in the first video, you can see. But as we finished the angio and we attempted to enter the sheath, we just couldn't enter the sheath. You can see the IVC. Since I couldn't enter the sheath delivery system, I did an angio, and you can appreciate that IVC is just going completely to the left side. So again, a 10-8 device was deployed, so there is no problem. So after doing this case, I thought, no, I know how to do azygonosis. So the third case came, and that is where the difficulty came in. This is a simple, again, PDA, and this is the first angio is normal. You can see there is no tube. The child does not intubated. Child just simple addition. Nobody puts a tube in PDA. But the second angio, you can see the patient is already intubated. So what happened? So I thought it's the novel PDA crossing was not difficulty, putting a sheath was not difficulty. I deployed 8/6 device, and what was the mistake I did, I will tell you once I finish the case. So what happens is that this is there, and as soon as I release the cable was released, the device embolized to the, you can see on the other side, the device embolized the right pulmonary artery. And that is device size, I think, was appropriate. The sitting was comfortably. There should not be any issue. Just that as soon as I released the device, cable, as soon as cable came out, the device embolized to the right pulmonary artery. So we tried to snare it, and unfortunately, we could not catch the screw, and we were able to hold the device. But because of the where azygonosis entering the SVC, we could not pull the device back into the right atrium. And I did angio, and I made multiple attempts, and we could not. So colleague took a jugular puncture, and we would hold the device from the jugular. And there also we unfortunately could not align the device, and so we kept it there. And we brought it near IVJB, and there. And the cardiac surgeon came, Dr. Agrawal, and he did small incision, robotic cath lab. By the time he was sure that it will be done, we put a device into muscular VSA device, and child was did all right. So I was a bit, despite doing 2 cases, despite doing normal procedure, with this I was a bit taken aback. Why did it happen? So probably I think the mistake which I did in the third case was that routinely the previous 2 cases, probably I think a simple PDA cable was there. This is a unfortunately, I think the ASD cable was used for the screwing the PDA device. Could it be possible that ASD cable could have the tension because of the curve through could have caused the problem? I'm not sure. I would take opinion from the experts. Thank you.
Dr. Rohit, you have any more patients? You told there are 4 and you showed 3. Is there a 4th patient also to be shown?
Yeah, that's simple PDA. That's basically coil embolization. That's not, you know, the small PDA, you can do coil embolization or ADO2 device. So to summarize, I think you can say that you can use azygous either IJV route, arterial reed, various options available. You can use coil, ADO1, ADO2 muscular device. That's operator choice is there. But I was a bit surprised and taken aback by embolization of the device, which I didn't expect. Probably I did use the ASD cable to screw the PDA. That could be what I think so, but I can take your advice.
Thanks a lot, Dr. Rohit. It was very informative. Yeah, I have had a couple of occasions of the same azygous continuation, wherein I have also taken the same route, sort of double looping around the heart. But one of the things that we need to realize is that the entire sheath will sort of straighten out, and there will be enormous amount of tension on the cable. And hence, after positioning the device, it may be a good idea to just push the femoral sheath way deep inside, so that it creates more and more loops within the right atrium, right ventricle, and sort of gives some sort of a redundancy of the cable and the sheath system. Then assess on the angiogram, and if you are comfortable, then release. But I'm sure, having done 3, you are definitely far more experienced, and it was lovely for you to have showed these cases. There were questions from Dr. Ko from Selangor, Malaysia, that an arterial access would have been a simpler option here by putting in an ADO2 device or a multifunction occluder device, or any device that can be deployed from the aortic end.
I think we did that. We put a muscular device in, since it embolized. I didn't have guts to put a jugular approach and put a PDA device. I put muscular VSD device when the device was retrieved.
So muscular VSD device was deployed like arterially.
Yes, arterially, correct, arterially.
Exactly, correct. The same question two, three persons have asked. The second question that has been asked is it easier to approach through a jugular vein, such a case of IVC interruption, rather than trying from the femoral vein? Have you ever tried through the jugular?
No, I'm all for it.
Yeah, I have also never tried. I have all done through the femoral. But Dr. Zahid, what is your opinion? Is it a good idea in IVC interruption to go through jugular route in case if the duct is not suitable for a retrograde arterial closure?
I would definitely consider going from the venous side, may it be femoral venous side or may it be internal IJ side, to be honest with you. Granted, if it's an older patient that you can access, we try not to access the artery as much as possible, so to save the artery.
As a matter of fact, Shiva, I'm back. I was lost because of Wi-Fi. The thing is that I have reviewed 2 cases for one of the journals wherein they went through jugular, and I thought it was quite a straight shot. It was not difficult at all. And these patients were not very tiny. They were grown up, like adolescents, And in both cases, they succeeded with a transjugular approach.
Okay. I have also not done a jugular route for a PDA so far. But one of the difficulties will be to get the circuit, to get the sheath all the way up. So in some of the cases, then I will snare the wire from the the femoral artery, create some tension so that I can advance the sheath, and having advanced the sheath, then release the tension, so that you sort of you give a slack on the sheath and try to avoid sort of a forward tug on the sheath. Then subsequently went ahead in closing the PDAs through the same manner like how Rohit was showing us. There are some more questions in the chat box. In long, big tubular PDA, what kind of device that you used? I think probably this was not a question meant for Dr. Rohit. Yeah, another doctor has mentioned that he has also, Dr. Neeraj Agarwal from Gangaram has mentioned that jugular is much more simpler. Yeah, I think it was a good way of discussing a patient who is not having a patent femoral, a straightforward venous access, then whether jugular will be a good alternative access for closing the PDA. Yeah, that was nice. I think Dr. Vijayalakshmi may be ready now.
Thank you.
Her internet is got completely cut off.
Okay.
So she said she will give me a call once the service is resumed.
So what are the other speakers in your list?
Now we have Dr. Sudeep Verma next.
Okay, yeah, Dr. Sudeep Verma from KIMS Hospital, Hyderabad, another very versatile interventionist. Sudeep, we are yet to see you.
So we can. I have unmuted you, sir. Sudeep sir.
I shared my screen also.
Not yet. Like no.
We are seeing you, Sudeep, but not your computer.
Now, sir?
Not yet. Sir, just press Alt S.
Alt S, sir. Just a minute, sorry for that.
Yeah, it's coming, sir.
Now I am audible, am I?
Yes.
Yes, sir. Good evening, everyone. So it's my pleasure to present in this forum because all learned speakers and all our teachers are there from whom we learn. It's not actually the embolization, but when I sent, they got selected. They told me to present this. It's a device closure for an interesting reason. Although in a 31-year-old, but it's very good to discuss all what are the options and what may be the other possibilities in that case. I am presenting on behalf of my department, Dr. Gautami, Dr. Padman, and all other cardiologists with that. So the case is around 31-year-old, showed up in the last 2 months with dyspnea, evaluated periphery and referred to KIMS for further management. No history of persistent curve, rashes, joint swelling, syncope, and fever. Weight is around 45, saturation 98%, all pulses well felt, but on the lower side with no radiofemoral bronchobronchial delay. Then 84 and the mean BP is 70 with JVP is little bit elevated above the clavicle plus 3 centimeter. Apex not well localized, muffled heart sound and with no murmur. Liver spleen not much palpable and chest was clear. So this is the ECG that shows the small complexes that shows when the muffled sound, and in this presence they already diagnosed outside as pericardial effusion and sent to us. So this is the echo when we did. We found out that in the heart there is a large chamber which is from the apex of the heart and which is like a LV outpouching from that. So this may be the various possibilities like aneurysm, diverticulum with associated pericardial collection. That's why she is having muffled pericardium as well as the BP is on the little bit lower side with this little bit elevated in the JVP. So with that, this is the echo that shows today picture as well as the flow to and fro across the diverticulum or the LV outpouching, and these are the different pictures in the echo that shows that. So with that, we thought whether it's a pseudoaneurysm, any other coronary abnormality or any other myocarditis which is causing the outpouching, or it may be congenital. We did the MRI also. That's also clearly showed there's a large aneurysm outpouching, which is more even the bigger than the native ventricle. So, and there is no gadolinium enhancement or no scarring seen. So with that, we can tell there is no enhancement, no scarring. So it may not be related to coronary, although coronary is also showed to be normal. And this is a very huge with the neck of around 17 to 18 mm. So this is the, in general, the picture of the large aneurysm which is outpouching from the LV apex. So complete diagnosis, we thought it is LV diverticulum, LV aneurysm on moderate pericardial collection and the LV dysfunction. So this is the pictorial depiction that shows the LV as well as the diverticulum with the rim of pericardial collection. This is the aneurysm, pericardial collection, neck. And because we before I joined to one of our consultant did the intervention and they found out even the largest device they're unable to sit. They use around 26 when the neck was 20 and that got embolized there to send. So we were very much particular because it's a wide neck. So what is the exact size in all dimensions? So it is around in all dimensions coming around 17 to 16 mm. So this is the, with that we thought we'll again try the device closure in that. So we, with the preparation, surgeons stand by, PET cell arranged, intubated catheter, noradrenaline given because the BP was consistently on the lower side. Antibiotics given, right femoral artery and venous puncture also taken for the safer side if any mishap happened. And the expected problem in such cases, because we have to expect when we are taking that, it might be a rupture when you are handling more into the aneurysm or the device embolization, you're unable to get proper, or the rhythm disturbances when you are entering the LV and then going to the aneurysm. So hemodynamic, the EDP was on the little bit higher side. And this is the baseline X-ray. You can see the gross cardiomegaly in combination with the aneurysm, and the axis is towards very much into the diaphragm down into the stomach. So this is the coronary evaluation as a routine. We did. It was turned out to be normal. No coronary abnormality was found out in this. And we took the JR. But as soon as we take the JR, the wire directly entered because the axis, if you saw the X-ray, it's exactly into the plane of the aneurysm. So with that, it was easy. Once we enter the catheter into the LV, directly enter into the aneurysm, and we make a coil. It's a well aligned with the JR 3.5 diagnostic catheter with thermowire. After that, once we put the JR inside, we just give the hand injection by seeing that. So you can see there is a large aneurysm with the very big neck, and the wire and catheter is well aligned into the aneurysm, which shows the swelling and the sluggish flow in this. So we put the Cook Employeds wire, and then the check flow performance sheet 12, and then we did. So this is the pictures, and after that we saw this, the again with the sheath injection we saw, and then this is the. So we decided, because it's around 16 mm, we thought we'll put the muscular device, and we thought because we need little more disc retention, we thought we'll use the post MI VSD in this. So because the advantage of having the 10 mm disc more on the retention side rather than the 8 mm muscular, and the disc length also is 10 mm rather than 7 mm. And the standard size what is the 24, we thought we'll use the 24 for the same for the 16 mm. So after that, it was, you can see the simultaneous echo, because we did a transthoracic imaging with the images were good. So that is the disc release image, and you can see in the different view. This is the REO view with the good waist formation. This is the LO view, and there's the LV, and there is no, and you see as soon as we close, there is a stasis in the side because there is no any residual or there is no inflow to the waist. So this is the different, as I told, after the release. With that, we were happy because there is no clot in the LVB check. The BP was maintained, and there was no movement of the disc, and it is quite wet hold in the neck of the aneurysm. So we thought this is the good. And the post procedure we extubated in cath lab only. Hemostasis achieved, stopped, noradrenaline, baseline BP improved and shifted to ICC. And this is the device after final release. You can see when we measured after that also the retention, the waist, it coming around the 17 mm. But because one case we did 4 or 5 years back, it got embolized even after taking 6 mm, because it's a very dynamic structure. We want to be sure, we want to take the bigger device so that it will hold it on well over there. So this is the thrombus sac. After that we see, and it's a pericardial collection. And this is the pre-discharge echo. You can see the pericardial collection is not much, it reduced, and the device is well stabilized and the function is better with the good BP. And this is the pre-discharge X-ray, and the post-positional discharge on day 2 and 5-month follow-up, having thrombosed sac, and he was asymptomatic and discharged on dual antiplatelet. So when we really, it's an aneurysm or diverticle because it's a ratio of connection of the body to the anomaly is more than 1. So it most look like a aneurysm and diverticulum. It's a more finger-like, but, and this is the pictorial depiction of both, and these are the associate anomalies with that. But in this case, there was no associate abnormality, and these are different classification given. And these are the 4 outpouchings. Out of this, we thought it's a LV aneurysm which we close with this device. So it's a mostly it's a pseudoaneurysm, most common after MI, but we did the coronary angio and we proved it's not because of the MI. So it's a congenital aneurysm as we thought, and which closed with the bigger device of the 24 mm post MI after thorough investigation. So thanks all. We always think that being a good team is always a success. So we are blessed with having good team. So thank you all for your kind listening, and I thank everyone who got involved. So I am now ready for the questions, if anything, and then any input from the seniors and our so they can give good input. How else we can do, or is it the correct or any other thing to be added up to that? Thank you for your kind listening.
Thanks, Sudeep, for presenting that very interesting and probably very uncommon case of left ventricular aneurysm stroke diverticulum. You know, I don't think that it is very easy to separate congenital aneurysm from a congenital diverticulum. The only one of the ways I remember, if you see, we have published fetal LV diverticula maybe 15, 20 years back. I presented 4 cases from Children's Hospital in Boston when I was there with Lisa Hamburger. And one of the ways of differentiating is what they call as a windsock appearance. If you have a windsock appearance within that structure, it is more like a diverticulum and less likely to be an aneurysm. And the other thing used to be whether it has, how much of muscle content it has. And based on that, they used to decide that diverticulum did not have too much of muscle content, whereas aneurysm probably had.
This on MRI found out to have no muscle content so much. It's like a thin output. So it may be diverticulum which increase over the period. Sir, I am
My
completely.
question to you is that before doing all this, did you rule out infective pathology? Means, did you do all the investigations for any underlying infection?
So the high sensitive CRP we did, all CRP as well as we did, as well as the purpose of doing was MRI is that to find out any scarring on it that in presence of infection or myocardial infarction which is causing the outpouching. And as such, she's not having any history of any infection also, but yes, whatever the routine investigation not seems to be fit into any of the investigation which is called any of the infectious pathology fitting causing that aneurysm.
There is one question from Muthukumar. Would 3D echo have helped in defining this aneurysm better?
So actually we not did, actually to very frank, we not did 3D echo, but we in different views we got the exact measurement of the aneurysm as well as the neck of the aneurysm. Anyhow, when we thought we will do the MRI to rule out the other causes for the infection as well as the myopathy in MI. So we got the picture with that. So that's why we were clear. But as such, the 3D we also will add into that. But as such, the mechanism of that we may not be able to get with the 3D apart from the good picture, what we get and good sizing we can get. But what is the mechanism, muscle involvement, all we may not be get into the 3D. For that, we thought first we'll do the MRI to rule out all other various causes causing the scarring and gadolinium enhancement to call aneurysm. But yes, 3D echo also we can do for the proper sizing as well as the proper delineation, that is also acceptable. But we not did it unfortunately in this section.
Anil Singhi has asked, what size of post myocardial infarct VSD device did you use?
24, sir, actually. The
24 is probably the largest, or there
yes,
is
sir. This is the approved is 16 to 24. That is the 24 we used, because it's a 17 to 18 mm waist is there. So we want to be sure, because one of our senior, he did the same case like 4-5 years back. They just oversized with 2 to 3 mm and they got embolized immediately. So we thought we have to hold like a post MI to get it more minimum 6 mm so that it will hold better.
This question is from Dr. Sakshi. Could we have aspirated the blood from the sac immediately after device closure once we are sure that there is no residual flow?
So, but sir, then it is stable. That we not thought, to be very frank, sir, we should do or not.
No, I think that it will not be immediately. There will be some foaming and all. And what is the need for doing it? What is the need? If you are going to completely disconnect that aneurysmal sac over a period of time, if there is no inflow, most likely it will collapse.
Suppose if we send for surgery, we can send for histology, that will be different. But doing the intervention complicate it more, then it's not correct, sir. We have to make it as simple as possible. And
my question is, what was your antiplatelet anticoagulation protocol after having done this?
Sir, because it's already closed, there is no connection. So we just did with the dual antiplatelets, sir, with the aspirin as well as with the clopidogrel, sir. We not did the anticoagulation, but there is a controversy because some people are telling because it's a large thrombus, but it's inside into the cavity, it's not getting emboli, it's not connected to the veins, so it's still controversial. Some literature, what 1 or 2 cases, they started anticoagulation. Some people started only with the dual antiplatelet.
And also it is important to know whether there is any contractile element in that sac, because if there is a contractile element, till such time complete endothelialization occurs, there is a finite possibility that some clot might go across the device. But I think after first 3 months, once endothelialization and thrombus sets in, I think thereafter systemic embolization.
But if it's nice, because the one disc is completely sitting on the LV,
absolutely
still worried, you can do, sir, actually.
No, the issue is not of the disc, but what we call as foaming.
Foaming, yes,
because
sir.
of the polyester, which will not get immediately covered with endothelia. So if at all, you could pursue this policy of maybe 3 months of anticoagulation followed by antiplatelet, or in your case, even antiplatelets have done a good job. Question from Neeraj Avasti is, what long sheath did you use? Because some of the long sheaths, as you know, especially if the patient is tall, they may not be long enough to go into the LV apex.
So this we thought, because we arranged one flexor sheet also little longer, but here is just adequate because this is a girl with the height of only 140 centimeters, sir. So we able to get through into the, because we checked outside, with just the, not the exact measurement, but we thought when the height is there, so almost we thought we'll able to reach. And you see that she just reached the mid of the aneurysm, it not reach up to the tip of the aneurysm. So our purpose was solved. But yes, we thought if we not able to get it, then we got the 10 PDA sheet as well as the flexor shuttle sheet also, we kept it ready. But luckily it went without any problem, and because it reached the cross the neck, so we were happy. And because of the girl, she is a woman with the short height, we are able to get through itself.
My question to Shiva, who is an expert in transapical approach. Shiva, what would you think of a transapical approach to close this? Or you think that it is too much of a risk if it ruptures or something?
Actually, when I was listening to Sudeep in the first few minutes, the patient was in a sort of significant hypotension with a lot of pericardial effusion around, low volume pulses. In fact, I was having an opinion whether it is some form of a pseudoaneurysm, which is partially walled off because there is a lot of pericardial effusion around, and hence the situation was looking extremely as if it is a very destructive process that was going on in the apex of the heart, rather than something like a very well formed diverticulum which is having a good neck and then a definite next chamber. Definitely I would not have attempted a apical. One another option would have been a transeptal sheath would have been easier, or a right brachial or some sheath would have been creating sort of a very straight course. I'm just curious to know, Sudeep, what is the follow-up imaging now that you told it's 5 months? What sort of imaging, like whether MRI or CT, how is it looking?
Sir, actually, I was unable to collect, sir, actually. That's the mistake, actually. It's there, sir. We did not did the MRI now, sir. We thought once the 6 months over, next sitting after 1 month, we plan to do the MRI, because once it's 6 months over, everything ended, like, then we want to do the MRI again. This time we did just the routine ECG, X-ray as well as the echo, but I was unable to collect now because. But
not a problem. The echo showed complete remodeling of the sac. Is it disappeared?
Or? No, still it's not disappeared, sir. Still it's like a thrombose, but it's a little bit less radial force and little bit collapse. It's not completely disappeared, sir.
Pericardial effusion has gone?
Pericardial effusion is gone, sir, actually.
My another concern is that, when you have pericardial effusion, how sure are you that there is no myocardial rupture? See, so if you ask any adult cardiologist, if they have a pseudoaneurysm with pericardial effusion, the first thing that they will say is a cardiac rupture. So my question to you is that, did you have this thought in your mind that you should use a contrast echo to understand whether there is any communication with this cavity and the pericardial cavity?
Sir, actually, if you see, we not did the contrast echo. Initially, we thought it because of some coronary issues causing the infarctive and causing the weakness of the muscle and causing because of the pericardial effusion. But when we did the ECG with the adult cardio, we are unable to find out any changes. With the same, we managed for 1 day because she's having low cardiac output. So with the good inotrope, and then we sent for the MRI. And then what you told is correct, sir, but we not did the contrast echo, but we are unable to find out. We thought it may be because of the change in the hemodynamics and because the large cavity may be reactive. So that's what we thought. But to be very frank, we not did the contrast echo to check it, sir, actually. But that is good idea to check, because it's supposed.
Why I'm saying this, is because, Sudeep, if there is a contrast leaking, you have to be very careful handling your wires and all. Even a terumo, under such circumstances, can perforate this, parchment like whatever the structure that is, and can cause disaster on table. So one of the things that may give you, I'm not saying will give you, but if you see contrast spilling into the pericardium, you would be even more careful handling your hardware within that.
But sir, one thing on table we did when we are doing the echo and somebody is flushing. At that point, we are unable to find out any. And second thing, we anticipated that. That's why we intubated her. We kept the surgeon ready. If any, that's why we just used the 2-wire with very good looping. We made it so that it will not touch anywhere and it get accustomed into the aneurysm. So it can fit into the aneurysm. With that also, we thought that's why the expected completion, I told, it may be rupture, it may be tamponade, it may be sudden embolization or the VT. With that, we kept the surgeon and we keep the ready for that, the OT, sir. But luckily it not formed because we also not thought it will be easy, but as it in the apex. So once you entered the catheter, it automatically directed towards, without even wire also, it was going into that aneurysm only. But what corrects, we have to anticipate more so that we'll not have any trouble. So we anticipated what you told, it's very correct, sir. We have to check all those points and then we have to go with that, sir.
So I
One thing
think
that I'm not able to understand is why the patient was so sick if it was a congenital LV diverticulum, wherein there is a significant hypotension, low volume.
No, sir, I think the hypotension is because of the effusion, because once we started doing some inotropic support for 12 hours with little noradrenaline, it becomes she was not very symptomatic for the hypotension per se. Because even with that, the mean BP was around 70, 75 was maintaining. Just because we are about to start handling into the cath lab, we started touch of NORAD and some dobutamine so that it will not cause any problem. But I think once we close it, the waste of the circulation it will decrease, and we continue to have some diuretics after that so that it will not cause sudden increment in the LV EDP and cause the pulmonary edema. And over the 2 days, you see the discharge, the pericardial effusion already decreased without doing anything. We not drained, we not did anything. So I think just because of the aneurysm, there is a force, radial force, which is causing the reactive effusion with that. That may be our pathology, because no infective pathology and nothing we are able to find out, no coronary. So we postulate that it's the secondary reactive effusion because of that over that. That's what we thought, sir, actually.
I think we have come to the conclusion of this second edition, the first day of learning from the masters in congenital heart interventions. I would like to thank Zahid, Shiva, Varakan, Nageshwar, and all the other participants who
thank you, sir,
made their presentations, and all the participants and all the audience who actively interacted with the speakers. I think it was quite a great learning, very unusual cases, and great presentation. So let me thank all of you, and thank Satya and his team for giving us this opportunity to spend some valuable time together. Thank you.
Thank you, everyone.
And
thank you.
Again tomorrow.
Take care, guys.
4:30 for the second day of the second edition. Thank you.
Thank you, everyone.
Good to see you guys.
Okay, bye-bye.
Thank you so much. Can I end the meeting, sir?
Please.
Yeah.
Bye-bye.
Bye.